Thank you, Paul. As he said, we've been friends for 20, 25 years, and he called me a few weeks ago to ask if I would come down and speak, and I said, sure. And then a week later, he sent me the title of my talk, and I was a little surprised. So I looked up chameleons, and can I have the next slide, Paul? I'm not responsible for the title of my presentation. Paul did this. And so I looked up chameleons, and they have these big long tongues that can snatch out insects, and they eat plants, plant material and insects. People have them as pets, but I'm sure you were all intrigued by the title, and that's what brought you here, but they do not bite. So Paul is my remote control, so next slide. So we're going to talk briefly about the anatomy of the venous system. There are three main systems: superficial, deep, and perforators. The main aspects of the superficial system is the great saphenous vein, which starts on the medial aspect of the ankle, runs up the inner aspect of the leg, knee, and thigh up to the groin, where it joins the femoral vein at the saphenofemoral junction. The small saphenous vein, and years ago they changed the nomenclature. There is, it's called the great saphenous vein. It's not the greater or the long saphenous vein, because that was confusing. So the great saphenous vein is on the medial aspect, and the small saphenous vein runs up the back of the calf, and it joins the popliteal vein in the popliteal fossa. And that location can actually be quite variable anywhere along there. The deep system runs in concordance with the arteries, and the named arteries, the named veins. The tibial veins in the leg, they coalesce into the popliteal vein. And then in the thigh, we change the name to the femoral vein. There's no more superficial femoral vein. That was too confusing. It's actually a deep vein. So it's the femoral vein. That joins the deep femoral vein to form the common femoral vein, then the external iliac at the groin, and then the common iliac in the inferior vena cava. And this is an MRI showing the venous system. And here's the aorta with the right common iliac crossing over the left common iliac vein, and that can sometimes compress that to cause what's called May-Thurner syndrome. Just a brief overview again. The superficial veins are in the fat layer under the skin. There's actually veins in the dermal layer of the skin. In the bottom layer, those are the blue veins you can sometimes see through your skin or your patient's skin. Those are reticular veins. The little capillaries that form, those are the telangiectasias. The perforating veins go through the fascia that separate the subcutaneous fat in the muscle layer, and the deep veins are in the muscle layer. The deep veins carry 90% of the venous blood flow in the legs. Upper extremity have the subclavian veins join the jugular veins, internal jugular veins, to form the brachiocephalic on both sides, and then the superior vena cava. And then in the arm, on the anterior aspect is the cephalic vein, which joins the axillary vein up by the shoulder, and then the basilic vein is on the inside of the arm, which joins the brachial vein just below the pectoralis muscle. There are several scoring systems used in venous disease that you might hear about. They may come up in the talks tonight. The first one, which is the most common, is called SEEP, which I'll go over in a minute. There are also other measures of clinical severity. This is the Venous Clinical Severity Score, Venous Disability Score, Villalta Score. They're all scoring systems to help grade patients and compare them. And then the government is more interested now in knowing not what the doctors thought of the outcome, but what the patients thought. So there's a big push on patient-reported outcomes of any devices, drugs, treatment. So patient-reported outcomes are more significant now, and there's several of them. This is a proprietary one called VVSIMQ, and there are several others. Paul? Thanks. The SEEP classification, which is commonly used, clinical, etiologic, anatomic, pathology. The one we use most is the C classification, 0 through 6. 0, no clinical signs. C1, telangiectasias or reticular veins or spider veins. C2 is just varicose veins. C3 is edema in the leg. C4A is pigmentation or eczema, and I'll show you examples of these. C4b is lipodermatosclerosis. And then you go from 4 to 6. You get an active ulcer, an open ulcer in the leg, and once that heals, you go back to 5. So you can't get to 5 unless you get to 6. And then there are other things that we use, and those are mainly to talk about patients in studies and research projects. Next. Briefly on the venous clinical severity score, the government and accreditation bodies are more interested in this as well. And this is physician generated, it's been well validated, and it's good to document changes in the patient condition. In this, there are 10 different descriptors, such as pain, pigmentation, inflammation, whether or not they use compression, and they're graded absent, mild, moderate, or severe, and so you can get a score of 0 to 30. And this is a good way to document changes in the patient's condition before and after treatment. So I'm going to give you some examples of venous disease. This is obviously C0, no evidence of venous disease. I'm always amazed that the stocking models don't need stockings, but this is a typical stocking model leg. You may hear about the gaiter area. The gaiter area is in the lower leg from the malleola to the upper calf, covered by the gaiters that have been worn for hundreds of years. And this is a typical location for the appearance of chronic venous disease. telangiectasias. These are intradermal venules of less than a millimeter or a millimeter or less in diameter, otherwise known as spider veins. And here's some examples. Like I tell patients, like real spiders, they come in different shapes and sizes. They can be raised ones, all different kinds of appearances. There's another example. Kind of looks like a blush or a bruise. That's called telangiectatic matting. That can happen from trauma, can happen from intervention. If we remove one vein, the body says, okay, I'm going to dilate these little microscopic red veins. And so you can get an unwanted cosmetic appearance where it looks like a blush or a bruise. Reticular veins are veins 1 to 3 millimeters in diameter. They're in the bottom layer of the dermis. They're usually tortuous, also called blue veins or venous ectasias. I don't know, this one may not show up, but here's a blue vein here. We have another better example on the next slide. So here's a typical reticular vein in the posterior thigh in the popliteal fossa. Varicose veins, usually at least 3 millimeters in diameter with standing. These are usually tortuous. They're in the fat layer under the skin. Typical varicose veins here in the front of the leg. They're in the fat layer under the skin. One of the areas where there's no fat is over the tibia or shin bone. So frequently you'll see veins there. And they actually may be normal. Lots of times you'll see normal crossing veins. They're visible, but they're not abnormal. They just happen to be there because there's no fat. Here's a very superficial great saphenous vein in a gentleman. Next, please. Feeding the varicose veins on the lower leg. They can come in all shapes and sizes. Why they occur on one leg and not the other, no one knows. They can be totally normal one leg and kind of horrendous on the other. And they can also be quite huge, typically in men who aren't as concerned with their appearance, so they'll wait till they get huge. Corona phlebectatica, which is a bunch of spider veins on the medial or lateral aspect of the foot, usually at the instep. The significance is somewhat controversial. They may just be associated with other spider veins, or they may be a sign of longer standing venous disease. We also call it ankle flare. Pigmentation, which is brownish staining of the skin from hemosiderin, breakdown of red blood cells, usually occurs in the ankle foot region or the gaiter area. This is an early skin change. So here's an example of ankle flare with the telangiectasias on the medial aspect and some pigmentation. Here's some more severe pigmentation. This would be stage 4B, C4, clinical disease. Venous eczema, dry, scaly, itchy, red skin. often associated with varicose veins, but may be caused by deep venous disease. Sometimes it's caused by topical application of lotions or creams, also known as stasis dermatitis. Here's an example. Here's a typical gator area, normal subcutaneous fat here in the venous eczema. Lipodermatosclerosis. I asked the medical students to translate that into 3 words: fat skin hardening or thickening. It's inflammation of the induration of the skin and subcutaneous fat. It can get quite fibrotic. Patients can have, if they have edema and they have significant lipodermatosclerosis, the fluid can't get into the subcutaneous tissue, so you see a Coke bottle appearance. Their upper calf is edematous, but their lower calf is thin and scarred from lipodermatosclerosis. Here's a chronic induration thickening. It's almost always associated with pigmentation. Hypodermitis or hypodermatitis is an acute lipodermatosclerosis. The patient may come in with some painful leg and the skin's red, and they get treated with antibiotics for 2 weeks and then 4 weeks and 6 weeks, and it doesn't get any better because it's not a cellulitis. It's acute inflammation. The treatment's not perfect, compression and nonsteroidals usually. Here's an example of acute hypodermatitis or hypodermitis. Next slide. Atrophy blanche. This is some depigmented scarred skin. It's white, typically surrounded by dilated capillaries and sometimes with hyperpigmentation, also known as white atrophy, and this is more of a sign of chronic venous disease. Here's an example. Here's a large varicose vein. Here's ankle flare, some pigmentation, inflammation, and next slide. Here's a close-up, and hopefully you can see the white areas here of the chronic scarred skin. Ulcers. Chronic open wounds are usually on the inner aspect of the leg. That's what delineates them as venous ulcers most of the time. They're on the inner aspect of the leg in the lower part. They have, if it's a venous ulcer, they have the other signs of venous disease, pigmentation and lipodermatosclerosis. Here's a typical ulcer. This is a 27-year-old gentleman, untreated ulcer for a year. There's a lot of biofilm on it. Here's another circumferential ulcer being treated with granulation tissue in it, but these can be obviously quite severe. There are lots of causes of leg ulcers. While most of them are vascular, either venous or arterial in nature, if they don't have any other signs and symptoms of venous disease, you have to think of other causes, whether it's vasculitis, metabolic, malignant, infectious, or miscellaneous. Okay. So what causes chronic venous insufficiency, all those changes that we see? The underlying problem is venous hypertension, high pressure in the veins. Normally there's low pressure in the veins, and when you walk, you squeeze your calf muscle and you eject the blood and the pressure goes down. Well, if there's reflux due to leaky valves or incompetent valves, the blood can't get out of the leg. The pressure goes up. Or if there's obstruction due to a previous deep vein thrombosis blocking the vein, or external compression such as May-Thurner syndrome, that increases the pressure. And so what happens is the red blood cells leak out, they break down, they leave the hemosiderin and stains the skin brown. The white cells leak out, and that causes the inflammation and the lipodermatosclerosis. So the underlying cause is venous hypertension, and that's what we try to do when we treat these patients, is to somehow lower the venous hypertension. So quick options for varicose veins. I tell patients there are 4 options. Do nothing, wear stockings and elevate your legs, non-surgical intervention, and surgery. Doing nothing is okay. Certainly if the patient is elderly, if the symptoms are minimal or not at all, that's okay for the asymptomatic patient. However, varicose veins don't get better. They don't go away on their own. The only time that'll happen is postpartum, if they develop during the pregnancy. Sometimes they can totally go away postpartum. Medications do not get rid of varicose veins. The claims that you see Venous and things like that don't make the veins go away. And the risk of untreated varicose veins, potentially bleeding from them, superficial phlebitis in a varicose vein, which is treated with warm compresses and ibuprofen, and progression of disease. Probably 1% of patients with varicose veins are going to get ulcers. However, you don't want, in someone who's young, if they are bothered by their varicose veins, they probably should get treated. It's a little depressing to see patients who are 75 sent to me when they've had varicose veins for 30 years that could have had them treated many years ago and done well with them. So option number 2 is stockings and elevation. Stockings come in all kinds of varieties. They can be knee-high, mid-thigh, full-thigh, pantyhose. I try to just use knee-high since they're the most tolerable, and the signs of and problems with venous disease happens below the knee. So the patients will wear knee-high ones. They don't help when they don't wear them or in the box or in the drawer. So most of the time, knee-high ones are okay. They come in different strength compression. Less than these are millimeters of mercury. They are graduated. They're tighter at the ankle than they are at the top of the leg. Oftentimes patients will say, oh, they cut off my circulation, I can't wear them. They don't cut off the circulation. They leave a line at the top because that's how they stay up. So the pressures aren't high enough to cut off the circulation. Unless you have arterial disease, and of course you should check the pulses before you put someone in stockings. They come in open toe, closed toe. They generally wear out after 4 to 6 months. When they get easy to put on, they're no good. As I said, they only help when you wear them. The major problem is patient compliance. Insurance coverage is variable. Some companies will pay for 2 or 3 or 4 stockings a year. Some insurance companies, I had one patient denied, and I looked at her policy, and it's totally excluded any surgical treatment for varicose veins. So insurance is you get what you pay for. Elevation, I tell patients ankle higher than the waist, off the floor is better than nothing. If they have severe venous disease or edema, I tell them the only time your foot is on the floor is if you're eating, walking, or going to the bathroom. If you're reading or watching TV, your legs are up. I tell them don't sleep on pillows. 5 minutes after you're asleep, you're off the pillows. Try to put something under the mattress in between the box springs so they can roll around all night long and their ankles will be higher than their waist. Stockings can be difficult to put on and take off. This is a simple device. You load the stocking on and you step into it. This is a more newer proprietary device from a stocking company that is water or gel filled, and it kind of rolls on and rolls off. It's quite nice. As far as non-surgical treatment, sclerotherapy, it only used to be for spider veins, and now with foam sclerotherapy and other modalities such as glue, we can treat the saphenous vein and larger branch varicose veins. And surgical treatment, which we're going to hear about later, I won't get into it, but the options are ablation of the small or large, small or great saphenous vein with different types. You can remove the veins, called phlebectomy, by making little incisions and pulling them out. There's no need to make big incisions. 2 millimeter incisions are fine, closed with steri strips, no scars. And occasionally we will still strip the great or small saphenous vein. So you need to correct the underlying problem, the venous hypertension, if there's reflux, and these patients all need a thorough ultrasound exam. The ultrasound can look at the superficial system, the deep system, the perforators, and if there's reflux, you can eliminate that with ablation, surgery, or sclerotherapy. If there's obstruction, which we'll hear about later as well, they can be balloon angioplasty and stented, or on occasion we can do a surgical bypass. Again, to decide your options, they need a full history and physical, obviously, a thorough ultrasound evaluation, and if you suspect obstruction, perhaps an MRI or a CT venogram. Thank you for your attention.